Good morning, everyone. Thank you for the invite. So I'm just going to share my screen here. Give me a second here. Can you see my screen?
Yes, sir.
Okay, perfect. Yeah, so once again, thank you. And thank you, Dr. Manju, for the kind invite to this meeting. And thanks for the kind introduction. So my topic today is talking about CLL in 2022. And in the next 25 minutes or so, I will take you through, the data and also some specific emphasis on the data from ASH, kind of what was added at the ASH meeting for CLL specifically. And then I look forward to the Q&A session at the end. These are my financial disclosures. So as you all well know, the therapy of CLL has changed dramatically. First major development, about 2 decades ago with chemoimmunotherapy with BR, FCR. And now since 2014, we have BTK inhibitor. The first one was ibrutinib. And now since 2022, I think there are some other expected BTK inhibitors which may get approved. I think the most, zanubrutinib is probably the closest one to be approved. We have a new PI3 kinase inhibitor, umbralisib. And then I also listed CAR T cell therapy, which is not, I'm not sure what the approval pathway right now is, but it will be some time, but still some ongoing trial. And then I listed pirtobrutinib, which is LOXO 305, which is also an emerging drug in the field of CLL. And I will show you some data, which was from the ASH meeting. So overall, the field has moved away from chemoimmunotherapy to targeted therapy. So let's first talk about the first line CLL. So these are newly diagnosed patients who need treatment for their CLL. They meet ideal CLL treatment criteria. So historically, we have certainly used chemoimmunotherapy, FCR in the young fit patients, BR and chlorambucil in older adults, and that certainly, still is used, I believe, quite commonly in India from the cost issue and other aspects. But at least in the United States, we have moved away from this strategy. And then in the targeted therapy era, the thought is that FCR could be considered for young fit IGHV mutated non-del17P patients, but practically for all others, we have moved to chemoimmunotherapy. We have moved to targeted therapy. And at least at MD Anderson, actually, we have stopped using FCR. We have a new regimen called IFCG, which we have used, but more recently also we stopped using it just because most of the doctors, my colleagues, myself included, and the patients, they don't want to get chemoimmunotherapy when we have really good options with BTK inhibitors and venetoclax. So really at this time at MD Anderson, we're using chemotherapy for no patients with CLL at all. Now, just as a kind of a background, when you look at the treatment options for CLL, what I just want to highlight is that, as I mentioned, chemotherapy could be used for this very selected group of patients. But again, at most centers in the US have moved away, including our own center. And then we have ibrutinib, we have acalabrutinib, and we have venetoclax approved in the United States in the frontline setting. And these are really the available options in the frontline setting for patients with CLL. And then just one caveat here is that for patients who have deletion 17p or p53 mutation, this 1-year therapy of venetoclax or obinutuzumab is not considered to be appropriate because these patients tend to relapse. So let's now first talk about the young fit patients. So these are patients who you would consider FCR-based therapy. So just kind of some, I guess, historical but important studies. First is a CLL10 study. This is again designed before the ibrutinib, FCR versus BR. This is now published originally in 2016, where they showed that the FCR is superior to BR for progression-free survival. Now, more recently, they did an updated analysis, which again doesn't really show anything new, except that the PFS curves are updated. But again, you can continue to see long-term PFS benefit of FCR versus bendamustine rituximab. And here the FCR, the median PFS, was just about 5 years or so for these patients. Now, obviously we have ibrutinib, and there are several randomized phase 3 studies which have come along. For these young, fit patients with CLL, so FCR obviously establishes the standard of care. So the first trial, which really head-to-head compared and tried to make a point that target therapies are better than FCR, was the ECOG trial, which Tate Schoenfeld presented a couple of years ago. So this is a very nicely done trial. For young patients, they got FCR versus ibrutinib rituximab, and ibrutinib obviously is continued until progression. So you get ibrutinib until progression. FCR is 6 cycles standard FCR. And this is old data set. This is data from now, not from this ASH, the previous ASH meetings, where ibrutinib is better than FCR. So this really trial established, for younger patient FCR, which was the de facto chemoimmunotherapy standard established, ibrutinib is performing better. And what they showed was that the performance of ibrutinib really was striking for unmutated patients because chemotherapy arm was not doing very well. But if you mutated IGHV, both groups were equally balanced, at least for the PFS, making a point that for mutated patients, yes, if you want to use FCR 6 cycle time limited, I think it's appropriate. But for unmutated, you can see a striking difference. Now, at this ASH meeting last month, there was a data presented by Dr. Peter Hillman from UK, which is a large randomized study called FLAIR study. So this is a very similar study to the Alliance study, or ECOG study, ibrutinib rituximab versus FCR. So large number of patients, FCR versus ibrutinib rituximab. So it's kind of the same trial design. The only thing here is they used oral fludarabine and oral cyclophosphamide as opposed to the IV version, which we typically use in the United States. Young patients, 60 median age, which is expected because we are comparing it with FCR. Not a surprise, ibrutinib performing better than FCR, as we saw previously. And again, not a surprise, mutated patients doing same, unmutated patients, you see a benefit. So all this looks very consistent with what we kind of already knew from a couple of years, that FCR versus ibrutinib rituximab performs better for overall and for unmutated patients. But one thing which came out of this ASH abstract was that the number of deaths were similar, but if you look at the causes of deaths in the FCR arm, MDS AML, somewhat expected, but then there were 9 deaths from cardiac-related issues in the ibrutinib arm. And they went further, and then they investigated these sudden cardiac deaths. And then they divided patients who have a prior history of hypertension or some kind of a cardiac disorder, or they were on some medicine, for hypertension or something from a heart perspective. And I would just want to highlight this for you is that there were 107 patients who, in the ibrutinib arm, who had this kind of a cardiac history, and in 7 of them, they had a sudden cardiac death. So that's obviously is a huge number of almost 7% sudden cardiac death in this group of patients. And this sudden cardiac deaths have been seen in other studies, I would say at a much lower incidence, but it's in this study in younger patients, that obviously is a much higher number. They didn't see that among the FCR treated patients. So again, I guess maybe a word of caution about ibrutinib in patients who have prior cardiac history, even if they are young. Median age here was 60s. Now let's talk about older patients. So these are the patients typically above 65 years of age in the practice. So again, what has been the standard here, at least in the United States, is based on this RESONATE-2 study, ibrutinib versus chlorambucil. And the most updated data we have, and now we have at least longer data, but the 5-year data showed 70% PFS at 5 years. So this is a number I might tell patients, or if they ask me in terms of long-term outcomes, that at least this large study, which led to the approval of ibrutinib, 5-year PFS was 70%. Now here, the control arm is chlorambucil. So you can argue that we don't have a perfect control arm. Chlorambucil is not commonly used. And then there comes the Alliance study, which was updated at ASH. So this is the ASH data where older patients were randomized to BR versus ibrutinib rituximab. And they updated the data at ASH. Both the ibrutinib arms are really, really superior compared to BR in terms of PFS. You can see how much improved the PFS is with the with ibrutinib arms And rituximab had no benefit over ibrutinib. So both arms are overlapping. So there is no reason to add rituximab to ibrutinib. The PFS, this long-term PFS, now kind of approaching 5-year mark, and no benefit at all. And again, with this longer PFS, the benefit, most of the benefit is coming for unmutated patients. If you look at the mutated patients, which are these dashed lines, the top one is the ibrutinib, and the green one is the BR. They are still pretty close together, but the major difference is among the unmutated patients. So not a surprise, but I think it's good to see long-term data showing continued superiority of ibrutinib-based regimen. Now, there are other BTK inhibitors besides ibrutinib. So we talked about ibrutinib, which hits many other targets besides BTK. BTK is a target right here, but it hits many other kinases. Zanubrutinib, slightly less. Acalabrutinib really hits BTK and maybe a few other kinases here. So it's much more selective among the three. And acalabrutinib is also approved in the United States based on this study, which is, again, a randomized trial comparing acala plus obin versus acala alone versus chlorambucil. And this data was updated at ASCO last year, where both the acala arms were performing better than chlorambucil. So now acalabrutinib is also available in the United States as an approved therapy for patients with CLL because it performed better than chlorambucil. Now, what was new at ASH was for the first time we heard about the zanubrutinib data in a randomized study in the frontline setting. So this was a large study. They had a cohort of patients without deletion 17p who were randomized to Zanu, single agent, versus BR. So again, a good comparator. And this is just one data slide I want to show you in the interest of time. Zanubrutinib is performing better than BR. So again, not a surprise here. This is what we expect. We know we saw with ibrutinib. This is what we expect with acalabrutinib. And now zanubrutinib is performing the same. And it is expected that based on this data, zanubrutinib will also get approval in the United States for CLL. It is not approved for CLL yet. Hopefully sometime this year. So then we will have 3 BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib for patients with CLL. And all are, I guess, in terms of the efficacy, they all look quite good and quite similar so far. Now, one of the other important things that's happening in the field is that, these BTK inhibitors are fantastic. But the problem is that they work, you have to give them continuously. Obviously, in the context of India, that will add the cost because you're saying you keep taking it forever. And then they don't lead to CR rates, and MRD negativity is really practically unheard of with single agent BTK inhibitors. And then we and others have been working on therapies that can you do time-limited therapy for these patients, as we were doing with FCR and BR. Why we suddenly moved to lifelong BTK inhibitor therapy, and why can't we just do time-limited therapy, be done with it, and then wait for the disease to come back, and when you can possibly resume the same thing again or do something different. But you don't need to be on continuous lifelong therapy. So in this, the first major development was what is called the CLL14 study, which led to the approval of venetoclax obinutuzumab. Now, this is which has been presented now several times actually. Venetoclax obinutuzumab compared to chlorambucil obinutuzumab. This is the data from last year, I think it was EHA, where when obinutuzumab, 74% PFS at 4 years, better than chlorambucil. So at least now in the United States, we have these 2 major trials which tell us, one trial tells us the RESONATE-2, that the ibrutinib is fantastic. Then we have the CLL14 trial, which tells us when obin is fantastic. And I try to compare these 2 trial PFS curves head to head in a way. And they look very similar so far, with the caveat that when obin is a 1-year therapy. So you're done with 1 year, as opposed to ibrutinib where you have to take lifelong. And then when you compare these 2 trials, obviously you want to compare what their baseline characteristics were, what are the other factors. And actually they seem pretty comparable, with the caveat that actually more patients in the when obin arm had more comorbidities as opposed to the RESONATE-2 study with ibrutinib. So to me, when obin is actually, I'm using that quite commonly in the clinic outside of a clinical trial setting because of being a time-limited approach for patients and seems to be doing very well compared to lifelong BTK inhibitor therapy. Now, one group which doesn't benefit the most is the TP53 group, where if you do this 1 year of therapy with ven/obin, these patients continue to relapse. So that's not the ideal strategy for those patients. So from a clinical perspective, and this is the discussion I routinely have in the clinic or with the patients, we have 3 approved strategies in the frontline setting: ibrutinib, acalabrutinib, which are lifelong BTK inhibitor, and then ven/obinutuzumab, which is a time-limited therapy. But there are pros and cons of these approaches. Certainly with ven/obin, it's time-limited, but then you have to monitor for TLS, you have to do obinutuzumab, which is IV, neutropenia grade 3 or 4 is 50%. And then, as I mentioned, P53 patients do not benefit long-term. So when I discuss these strategies, I would say in my clinic, most of the patients go for ven/obin because they like 1 year approach for these patients. But certainly, acalabrutinib and ibrutinib are excellent choices as well. Now, one new data set for a time-limited therapy at ASH was CLL13 trial. So the question always has been in the field of, do we need obinutuzumab? Can't I just use rituximab for my patients with venetoclax? And we know obin is better than rituximab with chlorambucil from a CLL11 trial. But we didn't have a data with venetoclax up until this data, which is the CLL13, where chemotherapy was compared to venetoclax rituximab, to venetoclax obinutuzumab, to venetoclax ibrutinib obinutuzumab, so triplet. So 4 groups, 920 patients, so large study. And just I want to show you the summary slide. They only reported the the MRD data. With chemo, MRD was 52% in the blood. With RVEN, 57%, no better. But when they add the obin-ven, you see a dramatic improvement here of almost 30 percentage point. And then the triplet was kind of the same as the doublet. So really, so far maybe establishing that ven/obinutuzumab is really better, and it is certainly better than rituximab venetoclax. So I think obin does add high rates of MRD negativity for these patients. Now, we talk about BTK inhibitor, we talk about BCL2 inhibitor, which is venetoclax CD20 antibody. But then we and others have started to look at the doublets of oral therapy, BTK plus BCL2. And some people are now looking at all triplet together, but it's not really clear if you need triplet or not. So when you talk about this doublet, so we started working on this concept now around 2015 or so. This is combining ibrutinib plus venetoclax for frontline therapy of CLL. So here we give 3 months of ibrutinib, and then we do add venetoclax, and then the venetoclax goes on, the doublet goes on for 2 years. And then if you're MRD positive at 2 years, you can get a 3rd year of therapy as well. So in this trial, we enrolled 120 frontline patients and 80 relapsed refractory patients. So at the ASH meeting, we updated the data for the first time for the 120 patients, where you can see their median age was 64 years. These are high-risk patients, high-risk genetic patients. So majority of the patients were unmutated. You can see 1/4 of them had TP53 or deletion 17p. And this was the updated data on an intent-to-treat analysis. In the bone marrow, at 1 year, 52% were MRD negative. At 2 years, were 64% MRD negative. And it's the best response at any time during the study, 72% were MRD negative. So these are the final, intent-to-treat analysis for these patients. So now, majority of these patients have stopped therapy at 2-year mark, and we are watching them in the off therapy phase to see what happens. And this is their PFS. Our median follow-up is close to 44 months. So this is a somewhat of a mature study, and you can look at the PFS looks really quite well. There are only 2 CLL progressions and 2 Richter's transformation in this 120 patients, and it's upwards of 95% or upwards of 90% here. So that looks quite good at almost 4-year mark with these 2 oral drugs together. And we are not alone. Captivate study, which is a much larger study, international study, also updated the data at the ASH meeting. And this is a much bigger group of patients. And what you can see here is that the PFS for all their different randomized arms, and I won't go into that, but I just want to highlight is that you just look at the PFS curves. They look fantastic with these two oral drugs. So our MD Anderson data, which was a single center study, and this multi-center large study, pretty consistent results of very excellent PFS for these patients. And there are triplets going on. So basically you do ven or ben, and you pick your BTK inhibitor, ibrutinib or acalabrutinib or zanubrutinib. Multiple groups are looking at it. We are also actually looking at it. I'm not going to go into the data, but so far it's not clear whether the triplet is adding anything to the doublet. And I think we have to wait for the PFS curves to mature to see if the triplet will do any better, because all the regimens are looking great and doublets are looking great as well. So I think based on the MRD, it's difficult to say because all the trials are showing 75% MRD negative rates. Whether that will mature into a better PFS remains to be seen. Now, what's coming for CLL? Frontline. There are many trials which are ongoing right now. The most advanced, I guess, is this trial, which is FCR versus Acala-Ven versus Acala-Ven-G. Again, the goal, as of all if you see here, is to get these doublets and triplets, compare them to get approval. So this is a trial which we are waiting for the results. We'll see when that comes out. But there are some other trials where you can see some of the new trials, the chemotherapy is all gone away. The control arm is actually not chemotherapy. It's either ibrutinib or Ven-G. So I think the field of CLL has evolved where the standard of care has, at least in the United States, has become non-chemotherapy approaches. So in the field of CLL, in the frontline setting, we have BTK inhibitor, we have BCL2 inhibitor approved. Ibrutinib plus Ven should get approved sometime this year. Whether we need triplets, who knows, remains to be seen. And then most of the therapies are being done for 1 year. I think that will be the approval. But we truly don't know if you're using this ibrutinib-venetoclax combination, do you need 1 year or 2 year? That remains to be seen. Now I have only like 3 or 4 minutes left, but I think I will hopefully finish on time. So I just want to briefly touch upon relapse CLL, and I will show you, I think, 3 data sets. First is that this is not a new data set. This is from last year. Because now that we have multiple BTK inhibitors, the question arises, which one is a better or which one is a safer? So this was addressed first in the Elevate study, Elevate RR study, where patients who are relapsed refractory, they were given Acala plus Ven. Acala versus ibrutinib. Head-to-head trial. Efficacy, same. No difference in the efficacy. But safety, better for Acala as opposed to ibrutinib. So you can see 16% AFib with ibrutinib versus 9% with Acala. Bleeding less, hypertension less. So safer, but equally effective Acala when you compare with ibrutinib. What about zanubrutinib? Zanubrutinib is a similar trial, Zanu versus ibrutinib. Just going to show you one data slide. Less AFib with Zanu compared to ibrutinib. So kind of the same theme. The second generation BTK inhibitors, Acala Zanu, are safer than ibrutinib and appear to be equally effective than ibrutinib. The last data slide I want to show you is pirtobrutinib, which also previous name was Loxo. Okay. Pirtobrutinib, which is Loxo 305. So this data, you remember like a few minutes ago, I showed you the kinome profile of ibrutinib, acalabrutinib, zanubrutinib. They were hitting some other proteins, some other kinases. This drug just hits BTK, nothing else. It's a very, very potent BTK inhibitor. A large study was reported, 261 patients with CLL. All of them, what they reported was had ibrutinib, 40% had venetoclax. So, somewhat of a refractory patient population, 3 prior lines of therapy. And look at their lymph node response. All these patients had prior ibrutinib, Some had failed ibrutinib, some had toxicity to ibrutinib, but you can see a uniform, practically beautiful lymph node response for these patients. And what is also important about this drug is the safety. So they reported safety, combined safety analysis of CLL and NHL patients, 618 patients. And look at the grade 3 or 4 adverse events. Practically nothing. Neutropenia, but besides that, AFib is less than 1%, hypertension to like really non-significant. So this drug actually is it's a very, very safe drug. I have treated a lot of patients on this drug, and really patients have really practically no side effects. So a safe and effective drug for relapsed refractory. And now this drug is moving into the frontline setting and is also going for approval strategy. So this will be actually a very important drug for the field of CLL and for the patients. So my last slide, this is kind of, I just maybe made highlights from ASH 2021. Certainly, zanubrutinib, a new BTK inhibitor, will come in the market for CLL. We should also see this doublet of ibrutinib plus venetoclax coming along for CLL. What we also learned is that UBIN is better in CLL compared to rituximab when you combine with venetoclax. So if all things being equal and UBIN is also available, then yes, UBIN should be the way to go. We don't really talk about this, but the question of 17p53 patients remains intriguing. What is the best therapy for them? In our center, we use BTK inhibitor therapy, but BTK plus Ven is also looking quite promising in some retrospective analysis. LOXO 305, as I mentioned, safety is really excellent and efficacy. We did not hear much from ASH, from CAR-T, and that's why I didn't include the CAR-T slides because they were from the previous ASH. But I think hopefully this year we should hear some updates on CAR-T specifically for CLL. So with this, I would like to conclude and thank you for listening and happy to take questions. Thank you.
Thank you, Dr. Nitin Jain. Excellent presentation and update, and thank you for updating us with the latest data and with the latest molecule with good safety profile. Over to Dr. Hari Menon. I am sure there will be lots of questions. Over to Dr. Hari Menon.
Thank you. Thank you. Hello, Nitin, and always nice to hear, and always as lucid as ever. So I don't see any questions, but I'll start off the discussion with a few points. Number one is you yourself mentioned in your talk that is a time for us to really do away with chemoimmunotherapy, compelling evidence, and on the verge of it being discouraged as part of any protocol. And number two, why is still smatterings of studies going on, still looking at chemoimmunotherapy as one of the comparators when we are looking at treatment? Is it just to demonstrate the profound activity of these medications, or is there some scientific basis for that?
Yeah, so I think first of all, nice to see you, Dr. Hari, as always. And I think so. I would say that practically most of the randomized trials which were designed 3-4 years ago, and you're seeing the results now, they were designed at a time when chemotherapy was considered the standard. Moving forward, the new trials which are being designed are all with non-chemotherapy, except the LOXO 305, which I showed you. So they are going to do BR versus LOXO 305 in the frontline CLL. Obviously, that trial is not going to really accrue in US because US, no one is using BR these days. So that trial, I think they're going to run in Europe, where still from cost perspective or national approvals perspective, BR is still considered, an appropriate strategy, as is, I'm sure, in India. So they're going to run that trial in the US, in the UK, in Europe. Your point is well taken, right? At the end of the day, they want to get the drug approved, and going head to head with ibrutinib or acalabrutinib in the front line, though maybe the most ideal strategy, may delay their approval or maybe a risky endeavor. So I think there's some business decisions they have to make there. But at least in the US, I don't think FDA would allow a frontline study for CLL approval with chlorambucil anymore. BR may still be considered appropriate because, but chlorambucil, I don't think they would allow that at all.
Yeah, thank you. And number two, next is coming to the MRD as a marker for us to determine how long you should continue the medications. Now, setting aside, of course, the IGHV unmutated and also 17p deletion, and when the issue is about continuing therapy and also sustaining therapy over here, are there some studies looking at whether you can, say, for example, at 1 year, look at the MRD negative status. Suppose the patient is on venetoclax, because these are expensive medications, and suppose we are implementing such treatments or we are counseling patients for such treatment. Maybe some of them can continue about 1 year. And if you were to achieve that MRD status at the negative status, would there be a scientific basis to say that, okay, instead of the 2 years that is being prescribed right now, whether we can go away at 1 year without taking the medicine?
No, so in the frontline setting, the approval is for 1 year when obinutuzumab, and the relapse setting is for 2 years, where ven is continued for 2 years. So in the frontline setting, it's 1 year, and the recommendation is really to stop at 1 year, irrespective of the MRD. And the question becomes in the US, because many investigators, including me, check the MRD at the end of 1 year. And then the question becomes, if you're MRD negative, okay, that's great. And you use a therapy was for 1 year, patient became MRD negative, everyone is happy. But if the MRD is positive, then what are you going to do? Should I continue venetoclax longer for those patients, or still I stop at 1 year because the recommendation is for 1 year? So that becomes a question which now will be addressed in a clinical trial called the MAGIC trial, where they will do some randomizations based on that. In the relapse refractory setting, where the venetoclax duration is for 2 years, can you stop therapy at 1 year mark? I think that's a good question. No one is specifically looking at it per se. I would say that I have some patients who have become MRD negative at 1 year mark. And if they're having some issues in terms of tolerability or some neutropenia or whatever, then I'm a bit more comfortable stopping it earlier, because it kind of makes sense intuitive that you're MRD negative, you have achieved a deep remission. But I don't think any study specifically is looking at that in a randomized fashion.
And before I ask my next question, there's some question in the chat box, and the one question is, what evaluation would you suggest prior to start of a BTK inhibitor in patients with coronary artery disease?
Yeah, so the standard we do in our is just the echo and the EKG and echo, and just to make sure their AF is fine, and if their hypertension is well controlled on the antihypertensive medicines. I would say that in the United States, because of the availability of acalabrutinib, because of the data I showed you, that acalabrutinib has less side effects than ibrutinib, and this data with certain cardiac deaths with ibrutinib, which has not been shown with acalabrutinib, myself and most of my colleagues at Anderson and elsewhere have moved away from using ibrutinib. So I'm practically not using ibrutinib. I'm using acalabrutinib for all my patients. Because acalabrutinib still has that risk of hypertension and AFib. So as a standard practice, I do, as I said, do an EKG, echo, make sure the blood pressure is fine. I do try to avoid, I think the second question I can also see in the chat with Dr. Manju about the antiplatelet therapy. Given again availability of venetoclax, which doesn't have that issue of bleeding issue or platelet aspirin antiplatelet issue, and so if a patient is on anticoagulant, if they're on dual antiplatelet, for sure, I'm not using BTK inhibitors, just because I'm worried, even a small risk of bleeding. Why to take when you have an agent like venetoclax, which is time limited and does not lead to bleeding complications? So if they're just on aspirin, it's okay, acalabrutinib is fine. But if they are on Xarelto, some kind of a anticoagulation and Plavix plus aspirin, and they had a recent heart stent or whatnot, then I'm not using, just because we have availability of venetoclax.
So the same question which I was also proposed to ask about Richter's transformation in CL. Suppose the patient has not received any, he was on follow-up on CLL and is not, and then has a Richter's transformation. How effective are these BTK inhibitors under the circumstances? And what is the impact of venetoclax in this situation?
Yeah. So, single agent ibrutinib or acalabrutinib probably has limited role in Richter's transformation. There's some data with acala, but they said 40% response rate, but the median PF is like 2 months. So that's just based on the next scan when you did the next scan. So it's not really very effective. There is data with R-CHOP plus Ven. There's data with EPOC-R plus Ven, which was just published in Blood. Our group is a part of that. We have worked on checkpoint inhibitors. Actually, I did include the slide deck. We had a presentation on atezolizumab, Ven plus obinutuzumab in Richter's transformation at ASH meeting. And we have done previous work with nivolumab in the Richter's transformation field. And then, so I think the goal becomes get the patient in remission of some kind, whether it's if a young patient, do R-CHOP Ven, non-del 17p R-CHOP Ven. If a 17p patient, we try to do a checkpoint, avoid chemo, do nivo, ibrutinib, or we had the trial with Ven-based atezolizumab, and then get them to transplant. There's also some data with LOXO 305, the pirtobrutinib, which was reported at last year. With single agent LOXO, majority of the patients, there were 17 patients, and actually I have several patients on that trial. They can respond very nicely, and I had a couple of patients who were able to go to an allo transplant as a next step after LOXO. So we're going to have a trial with LOXO plus Ven plus Obin as a strategy for Richter's in about 3 months at our center. So that will be something, we'll see how that pans out. But yeah, I think it remains a tough disease, tough thing to manage. I mean, I would say none of the strategies I'm telling you lead to long-lasting remissions unless you can get the patient to a transplant.
Right. And there's another question by Dr. Prasad. And his question is, can BTK inhibitors do what TKIs are doing in CML? And are we moving that way?
I mean, yes and no. I mean, I think CML story obviously much different. If you have one genetic abnormality, it works beautiful. Patients are living forever. I mean, normal life expectancy.
Yes.
But I think BTK, to some extent, yes. But as you saw if you compare the PFS curves for CML patients versus CLL, CLL patients still are relapsing. And now, what's happening is there are multiple patients who are, because, they started the ibrutinib some years ago. Median PFS with frontline ibrutinib is 7 to 8 years. So they will relapse. Then they will go to venetoclax. And they will relapse in 3-4 years. So I think we'll eventually have a pool of patients who have failed multiple lines of therapy and they're living longer. And then they will need more subsequent therapy. So in some sense, yes, they are doing the same thing as TKI, but CML story is obviously much different.
And intrinsically, the inability of BTKs to induce MRD negative status.
Yeah, that's a perfect.
That's
argument.
fundamental for yes.
Yeah.
So I've asked this question several times. We know that obinutuzumab is a lot more potent than rituximab, but essentially the mechanism of action is the same. Then why this great difference where rituximab has really not added too much to the armamentarium of except when, of course, using it with venetoclax but not so much when using it in combination with the BTK.
Yeah. So it's don't know for sure. Some simple observation is that when you use obinutuzumab, in terms of per milligram dose of obinutuzumab is much higher than what you use with rituximab in terms of milligram to milligram. So the amount of drug technically, the drug you're giving is much higher. Second is this concept about ADCCs and how these drugs interact in terms of NK cell function, like how ibrutinib or acalabrutinib these days drugs interact in terms of NK cell function and how much NK cell function for ADCC you need with rituximab versus obinutuzumab. So I think the preclinical data, initially suggested that combining rituximab with ibrutinib will be counterproductive, that there will be negative impact. In fact, there were studies which suggested that caution of using ibrutinib with rituximab. At the end of the day, we saw that there was no benefit. It's not that it was a negative study, there was no benefit. So I don't know, I guess whether it's just the dose of what obinutuzumab dose is given as opposed to rituximab. But at least the data we have with venetoclax seems to suggest that that's better, and there is no interaction as compared to BTK inhibitor where these NK cell interactions, venetoclax has really no effect on the NK cells.
Manjula has another question, and that is on mutated IGHP with no other high risk cytogenetics. Would you suggest BR in older individuals, given fixed duration and no overall survival difference, or would venetoclax or benitusumab would still be a preferred option?
So again, I think at our center, yes, venobinituzumab is the preferred option because we have moved away from BR, but because venobin, in all fairness, is also a fixed duration option, right? So we're not talking about lifelong BTK inhibitor, and so the concern with using again chemotherapy with the prolonged myelosuppression for some patients, infections, whether it's a bad option, no. I mean, certainly cost, if the cost is a consideration and venobin is certainly more expensive than BR, I think it's perfectly fine to use. I think in our setting, like in our setting where I am, just because venobin is so easily available, and it's also a time-limited approach, I go for venobin as opposed to BR. But yeah, certainly using BR is not inappropriate at all.
So just wanted to understand, we encounter quite a bit of toxicity when we use venetoclax in AML patients, and of course they're different. How is it to the same degree? What are the toxicities when we are combining venetoclax with ibrutinib as against using benitusumab?
Yeah, so obviously AML story is different. More myelosuppression, especially if you do ven-aza and you do continuous ven for 28 days. I think that will lead to myelosuppression. More prolonged myelosuppression. With venobinituzumab, actually, it's a pretty straightforward regimen. The main thing I see is neutropenia, 50% grade 3 or 4 neutropenia, which is something which you can check the counts, hold the drug, give Neupogen or GCSF to say. The TLS monitoring is more logistic issue. They have to come get the labs, but no one really gets TLS as long as you follow the parameters, hydrate them, give them the allopurinol. It's just they have to come frequently for the labs or monitoring. And after they finish the initial couple of months, it's pretty straightforward. I mean, no one gets any ibrutinib kind of side effects to say, and and the only thing you have to watch after that is just for neutropenia. When you add ibrutinib or ibrutinib plus venetoclax, which we did quite a bit, certainly then you run into the issue. Same neutropenia is still an issue, 50% neutropenia, but then you also then have to deal with ibrutinib side effects, some of these arthralgias and AFib and things like that. But overall, I think prolonged myelosuppression, if you're worried about, except I think one patient I had where he had prolonged myelosuppression, no one really had such a prolonged myelosuppression in my experience with venobinituzumab.
So I don't see any further questions, and I think we have crossed our time by 4 minutes, I think. Yeah. So from all the organizers and personally from my end, thank you for the lovely talk and the wonderful interaction and answering everything with so much clarity. And thank you, Nitin, for that. Yeah,
thank you very much. It's just before midnight
yes.
here, and I wish you guys a happy Sunday morning.
Nitin Jain. Thank you, Dr. Hari. Over to organizers.
Take care. Bye.
Thank you.